Well, hello everyone. It's a real delight to join you. I apologize that I can't be there in person. As it happens, my day job, so to speak, has me today in Oxford, where I'm participating in a steering committee, and I can't join you for this Congress, although I'm here in spirit. And it's my great privilege to thank you and everyone for receipt of the Raymond Barr Award of Excellence in 2012. This is a real privilege for me to receive this award, and I am honored by all of my colleagues who've chosen to award this to me, and quite privileged to have the opportunity to have been able to work with all of you in trying to improve care. Now, as you know, Raymond Barr is the founder of the concept behind this Society of Chest Pain Centers. This is something of visionaries, and Raymond is certainly one of those who recognized very early on that a heart attack is the end stage of a long process of atherosclerosis and then an acute event. And the way to improve outcomes is really to try and interrupt that process as early as possible, and as such to try and trigger the response to an acute MI as quickly as possible. And so the early recognition of symptoms outside of the hospital by the patients is the first alarm signal that a patient will get, and one that can really start the clock. And this is what Raymond got about 10 or 15 or 20 years ago, really, and which he advocated for a broadening of the look of where we treat heart attack patients to before the hospital, and reaching out to the community and educating patients and providers and helping build systems and rapid referral to the hospital was his vision. And in the hospital, he recognized that we need to cut through a lot of the red tape as well and create a chest pain center that could focus on the key aspects of care of both recognition and then early management of acute MI. And so out of that concept and his many publications and advocacy and speeches on this was born the Society of Chest Pain Centers. With colleagues who share this passion for early treatment. They founded this society over a decade ago, and I've had a privilege of being associated with it for quite a long time. Early recognition wove in early diagnosis with troponins and biomarkers, and then early response and building the rapid door-to-balloon time and door-to-needle time responses for ST elevation MI. And this really caught a wave of trying to improve management of the highest risk coronary patients, those with an acute MI. At the same time, in the hospital, again, it was reaching out to the community, and so building a continuum of care that starts with the people before they're actually patients, educating the general public about what are the symptoms that one would look for of an acute MI, and helping others develop a rapid response and building the emergency medical system's rapid response team, and then creating just that within hospitals. And so with that, the full response could really be enhanced and improved. And we have seen exactly that evolve over the past decade, a very, very exciting decade for acute MI management and in both recognition and management of patients. Now, from that concept emerged many new learnings, as has been said, where the key is really the system. And so it's no longer us trying to be good doctors and nurses and healthcare providers, but us working as a group and building a positive system to try and improve care and streamline care to what is needed, cutting out unnecessary things, cutting out unnecessary delays, but then remembering to give all of the necessary and proven therapies. And so the notion of developing really critical pathways has emerged as the approach that the Society of Chest Pain Centers has shared with participating hospitals to say this is how we would aim to improve care. Now, in developing pathways and systems, one starts with a top-to-bottom review of how a given system treats a patient. And so first with acute MI, and as we'll come to, many other diagnoses can be streamlined and have improved care in this fashion. And so looking at where are the system delays within a given hospital, what is all the extra stuff that happens in the emergency department, how could we focus the attention to the chest pain presenting patient and do the required tests, get the right people in place, and get initial therapies started. And that process makes a hospital write down exactly what they would need to build the system. Now, monitoring data has also been seen to be a critical part of this. And so in looking at the initial response, does it take 5 minutes, 10 minutes, or 20 minutes to get an EKG done on a patient presenting with chest pain? Now we have all been working on this, and it's down to 5 minutes at most hospitals, but initial recognition of where were the time delays came from scrutinizing what we do. And so auditing current processes is a key part of this overall quality and systems improvement approach. Now, that's an ongoing thing, and so this process of looking at current practice, evolving that, writing down good pathways, and then monitoring that has developed into the real systems improvement approach that works. This has been shown nationally for the Door to Balloon initiative that people focused on just that one metric. And so the Society of Chest Pain Center said, we should really write all this down and see how good hospitals do this well. And when we find good hospitals like this, we could accredit them to say they do everything right. They've got all the systems in place, they're monitoring their data well. And so there evolved one of the key aspects of the Society of Chest Pain Centers is to do accreditation. Evaluating very carefully, holding hospitals to high standards on all the different components of a well-working system, and then, when demonstrated, accredit them to say this is a Society of Chest Pain Center accredited center for excellence in this case, acute MI and chest pain management. So that has been a terrific advance for the field to really hold people to a very high standard and to try and grow that. Now, out of this evolved participation in the Journal of Critical Pathways, where the Society of Chest Pain Centers has that as their official journal. I think it's on my back shelf here, all of the issues, where in each issue, many of the articles are experiences from chest pain center affiliated hospitals showing their improvement systems. But also all of the academic physicians involved in the Society of Chest Pain Center have been doing research in this area and publishing in this field to try and advance further the process of quality improvement and also to study it. Now, the other aspect of of this is that research in this field is a key component as a way to try and advance it. And so the Society of Chest Pain Centers is a member of the Action Registry Get With the Guidelines Steering Committee and official partner with the ACC and AHA affiliated registry. And in this, there is guidance on the data fields to collect, but also how to analyze data in terms of what are barriers to care, what are patients' aspects of care that are suboptimal still despite efforts at quality improvement. One really neat analysis was an analysis of hospitals, and this was done also in the Hospital Compare data set of those who were a Society of Chest Pain Center affiliated and accredited hospitals versus those who are not. And as you may guess, and likely not be surprised, that the accredited hospitals did a better job in meeting all the guideline recommendations. And so looking in further research of this from ongoing registries is another key aspect of the Society of Chest Pain Centers. Now, all of this success began with Raymond Barr's vision of how to manage acute MI and chest pain patients. But these processes are ones that can help many different diagnoses. And so heart failure is obviously another thing that fills our emergency departments. And Frank Peacock has long been a part of the Chest Pain Center Society and obviously is an expert in heart failure management, especially in the ED, and has helped champion a whole program of looking at heart failure as another area to develop the system's improvement. Atrial fibrillation is another very common one, and this process and accreditation approach is one where the society is broadening its scope to try and help care in so many different areas of acute management of cardiac patients. Now, this notion of aiming for high quality and fixing the system is indeed one that is being talked about as the way to fix or improve our whole healthcare system. And so the notion of redundancy and extra unnecessary testing is one aspect that hopefully one could reduce costs, but then recognizing there are many patients who are not being treated according to best practice and guideline recommendations, that aiming for high quality care that can then get rid of unnecessary testing and treatments would be a way to both improve the quality of care and reduce costs. And so this is really a major concept behind the whole healthcare renewal and initiatives, in addition to the national healthcare initiatives of expanding coverage, et cetera. And I'm proud to be a part of that concept of improving the efficiency and the quality of care as the way to move things forward, and the society is right there and has been doing it for a decade, showing improvements in care overall. And so a very exciting time to be part of the society and really make things better. Now, a final aspect of this gets back to the beginning, where it's a continuum of the patient's care, and of course that continuum involves a team. And being a part of a team is something that leads to success. And so we have, as part of the team, cardiologists and emergency medicine physicians and nurses in cardiology and emergency medicine, involving also the cath lab. And then also in primary care, they have the continuity of management of these patients both before, so that risk factors could be managed and avoid acute MI and heart failure decompensations, but then afterward to try and help on secondary prevention. And so the team approach is one that is very exciting, and obviously the way that we can work all together and improve all aspects of care. And so I want to thank all of you for the receipt of this privilege award, and it's really a tribute to all of you and to Raymond's initial vision of how to strive for better care for our patients, that we can really change the outcomes of them and modify and improve their lives overall. And so thank you all very much.